The main theme was consistent with the main RCT results, that the education provided and the rapport with the physiotherapist was a big driver of improvement. There were these unique benefits that were reported by the physiotherapy group or the rehabilitation group, and they perceived they were stronger. They had functional strength, running up hills, running fast, that kind of stuff. And they also perceived they had increased self-efficacy, control over their destiny, or better ability to manage flare-ups, better resilience. However, as you pointed out, we measured strength in the trial, and the group started at a pretty similar level and finished at a pretty similar level.
Now, you just would have heard a part of my conversation with Aidan Rich, who is the lead author on a new paper that just came out recently in the American Journal of Sports Medicine, and that is titled Physiotherapy Compared with Shockwave Therapy for the Treatment of Proximal Hamstring Tendinopathy, a randomized control trial. Now, this paper is open access. It is tagged below. I really encourage you to go and read it. The next best thing, of course, is going to be hearing from the lead author for 50 minutes. And I was surprised. I didn't think we would go for that long, but we did. And it's interesting. Aidan treats a lot of proximal hamstring tendinopathies at the clinic he is at down in Melbourne. And we spoke through if anything changes in his treatment modality and the way that he treats. Does he bring Shockwave in earlier? How do we think Shockwave works? How do we recruit the participants? How many participants there were? Talking about education, the exercise protocol, which has garnered some attention online and rightly so. Now, there are some awesome resources that Aidan encourages everyone to go and download and utilize with their patients, which I'll have tagged up below here. So I really hope you enjoy this episode. Head over to LinkedIn or actually give Aidan a follow. I really appreciate him coming on at such short notice. I mean, this is one of the awesome things about social media and podcasting is you can have a great paper come out, but you can truly have some long format discussions around. So I hope you enjoy. We've had some authors on some papers that have generated some hype, and I've got to thank Aidan Rich for coming on so soon. There was a recent paper that came out, and it was titled Physiotherapy Compared with Shockwave Therapy for the Treatment of Proximal Hamstring Tendinopathy, a randomized control trial. Plenty of hype on Instagram. It really challenged some biases between shockwave and exercise. And I thought, who better to discuss the paper than the person that probably knows the most about it, which is the lead author. So welcome to the podcast, Aidan Rich. Thanks for coming on.
Thanks, Blake. Thanks very much for having me on your podcast.
Now, can you give us a backstory of yourself, who you are, what you do, and we may as well just lead into why this paper.
Sure. So I'm a sports and exercise physiotherapist based in Melbourne in Australia. I graduated from La Trobe University with my undergraduate degree in 2004. And then when I did my sports and exercise masters in 2009, 2010, got the APA titling, and then returned to university again in 2017. And I enrolled in what was initially a Masters of Research degree, and then transitioned across to a PhD. And my PhD topic is treatment of proximal hamstring tendinopathy. And I guess why tendinopathy? I think when I went through undergraduate, things were changing rapidly. I've got a very clear memory of in 2002, so it was my second year of undergrad, a paper got passed around the auditorium, the lecture hall, and it was time to abandon the tendinitis myth. And there was the move from tendinitis, the inflammatory condition, to tendinosis or tendinopathy, and Karim Khan was the lead author. And Jill Cook, who was a La Trobe academic at the time, was a co-author, and it was a really big change in how tendons were managed. It went from rest, manual therapy, stretching, and inflammatory medication. It really did a complete 180 to an exercise program, a de-emphasis on anti-inflammatories and judicious rest or limited rest. And it was a complete 180. I thought, how does the treatment of these conditions change so much? Surely it's the late 90s, early 2000s would be pretty across things, but it really did a 180 at the time. And I saw a A4 poster on the top floor at La Trobe University. I was looking for research assistants for a PhD student who was studying patellar tendinopathy for their PhD, and it was Peter Maliara. So I walked into Peter's office and said, "You're still looking for a research assistant?" He said, "Yeah, that'd be great." I said, "Great." So I had these lovely long Saturday afternoons with Peter down at the State Volleyball Centre in Keysborough, data collecting and having great long-form conversations about sports physiotherapy and tendons. Peter's primary supervisor was Jill Cook. So we had this wonderful dinner with Jill at the end of the data collection, this Indian restaurant in Fairfield. We had great chats, and I had this great respect for both of them, Peter and Jill. And Jill was this kind of, she was really at the height of her academic career in that first decade of the 2000s with the Continuum paper and some of the stuff she was coming out with. And they were both passionate, enthusiastic, therapists, clinicians, and it really ignited my interest in tendinopathy. And then through the group I work with, Life Care Health, we'd had a few PhD students do their PhD, and we had a good model where we can run a randomised control trial through the network. So randomised control trials are expensive to run generally, but the way we've done it is we had junior clinicians, 2 to 6 years out of university, treat in the trial, and it keeps costs down. It upskills the junior physiotherapist to be very good at treating a condition. So we had a multidirectional instability of the shoulder PhD come through. We had 5 on back pain, and I liked the model, and I had some opportunity through my colleagues to do the same thing effectively. And I wanted to do something on tendon. I got back in touch with Jill. There is very little, as I think we'll talk about, on proximal hamstring tendinopathy compared to other tendinopathies, certainly. And we got a plan for a PhD up and running, and I enrolled in 2017 and finishing this year.
Wow. I tell you what, if you were to say, what is heaven, it would be to sit at that Indian restaurant with you, Jill, and Peter and hear about tendons. That would be so much fun. What a group, and it's so awesome to hear the journey. Like, did you find tendons interesting when you graduated? Like when you first started treating? Like, did you find like this is really cool and I don't really know how to manage these as well? Or we don't really know how to manage these very well?
Yeah, because things were still changing. We had, the Alfreds and stuff was late 90s. The move from tendonitis to tendinopathy was early 2000s. The Continuum paper was there. There was the polypill paper, which was Fallon et al., I think, 7, about the TNF-alpha antagonists with doxycycline and ibuprofen. There was this kind of back and forth between eccentrics and heavy slow resistance. Then isometrics came in a few years later. So things were rapidly changing. That was what I found interesting, where I'm trying to think of the condition where things hadn't changed as much. Maybe hamstrings, and they had 2 RCTs on hamstring muscle rehab. There's certainly more hamstring research going on, but I felt like with other areas, things weren't changing as much. And then tendons, really treatment went from do this to do the exact opposite over a 5 or 10 year span.
Yeah. And when was tell me about the first time, two questions. The first time you ever heard of Shockwave, and then the first time you ever utilized Shockwave, and then what did you think of it?
I started private practice work in 2007 at Life Care Croydon Sports Medicine, also Life Care Ashburton Sports Medicine. And we got a Shockwave machine at Croydon around that time, probably within the first couple of years. And I eventually got trained up to use it. And the first time I used it was on one of the therapists, Andrew, who's still there. He had some plantar fascia pain, some plantar heel pain. So I used it on his heel. And I remember at the time thinking, what are they like? Is there any evidence for Shockwave? Does it work? There were certainly people with strong opinions on it. There are still people with strong opinions on it, but that was the first time I used it.
Yeah, and what did you think of it? Like, did you, with your current understanding then, did you think this makes a lot of sense? Is it some neuromodulation, some descending inhibition? Like, what did you think? Because it is quite unique, and I use a Shockwave at the clinic for some things, very small amount of pathologies, but it's very odd, and patients say it's very odd. There's nothing that they've had like that before, very different to your typical manual therapy.
Yeah, it's a hard sensation to describe, isn't it? Like being hit repeatedly with a ball bearing is what I've got as close to. I haven't got any tattoos, but friends have said it's like getting a tattoo removed. I did struggle, almost say struggle, but I did not have a thorough understanding. I'm not sure if I've got a perfect understanding now of the mechanisms, and you raise a good point. Is it neuropraxic? Is there some descending inhibition? Is it some kind of mechanical stimulus to the tendon that does something by way of mechanotransduction? Certainly, at least anecdotally, there appears to be some good short-term analgesic effects. So there's probably something short-term at play there. There's potentially something long-term at play. One of the good things about Shockwave is the safety profile. They're very good. The side effect profile is good. There's very few substantial or even minor side effects.
And what had been done in the past? Had you, obviously preparing for this study, had there been any RCTs comparing for proximal hamstring, comparing Shockwave in isolation or Shockwave plus exercise and Shockwave together?
Yeah, in the total history before I started this thesis, there were 2 RCTs ever on proximal hamstring tendinopathy, and the first one was by the Italian doctor Angelo Caccio, based in L'Aquila. And he ran a study on 40 professional athletes comparing Shockwave therapy to, they called it traditional conservative therapy, which was ultrasound, like therapeutic ultrasound, massage, and then a generic stretching and strength program. And that, really groundbreaking research for 2008, which I think is when he started recruiting, or even slightly earlier, was published in 2011. I guess fair to say it's a bit different to the physiotherapy protocols that have been, or the exercise protocols that have been successful in other tendinopathies. But in that trial, they showed that Shockwave was far superior at every time point compared to the traditional conservative therapy. The second RCT on proximal hamstring tendinopathy was done by Davenport. I think it's out of the US, published in 2015, and they had 19 proximal hamstring tendons across 17 participants, and they compared PRP or platelet-rich plasma to autologous blood injection or whole blood injection, just kind of normal blood, and found no difference between groups. Trial's a bit tricky to interpret because you haven't got a baseline for how efficacious either of those treatments are. In any event, they showed no difference between groups. And then when we went to design this trial, the one that we just published last week, we thought, we're always going to do a rehabilitation, a physiotherapy-led rehabilitation group for the main intervention. What do we do for the control group? Do we do usual care and send them out into the community? Do we do a stretching program? Do we do a generic strength program? And we ended up landing on Shockwave, one, because it had demonstrated efficacy from that Acute trial from 2011, and two, because we had access to the Shockwave machines with clinics around Melbourne and Ballarat. So that was how we landed on the design for the RCT.
Yeah. Okay. And there's some good protocols. Oh, well, there's at least defined protocols for the Achilles, and there's a great systematic review, which I can't remember the author, but it's roughly 3 to 4 sessions, 200 hertz, and there's a little bit of a protocol there. But for the hamstring, and when you're designing this, what how did you land on? We talk about exercise and the dosage, but for Shockwave, it's the same conversation, just in a different lens of how often, what machine, how much energy, how long do you space it apart, how high do you go? If patients can tolerate less, do you just go to where they can tolerate it? Do you go higher? So how did all that kind of come about? Because I imagine there's not a lot to be able to base that. There's not a lot of previous trials to be able to base that on either.
Yeah, really good point. So the dosage we landed on for this RCT was 4 sessions of Shockwave at weekly intervals, and the dose was 2,000 shocks at the maximal tolerable intensity. So we had a variety of machines, and this was one of the challenges about standardising the trial. Do you just use one Shockwave machine only? It wasn't practical. I think we had 21 physiotherapists across 13 different clinics providing treatment. So we had a variety of machines, although most of them were the same. There were some radial machines and one focused machine, and I'll get onto the radial versus focused thing in a second. But the dosage, we had a few different ways to kind of calibrate it. I think it was the Schmidt's 2015 systematic review where they looked at safety and efficacy of Shockwave, and for tendinopathies, they recommended that 2,000 shocks at the maximum tolerable intensity, 4 sessions was safe and effective. And the Acute trial, I think, was very, very similar. I think there's one slight difference. It might have been 2,500, but it was one of the variables that was slightly different. I think it was 2,000, 4 sessions at weekly intervals. And maybe one of those variables was very slightly different, but it was roughly the same. I had a few comments along the way about radial versus focus Shockwave, and sometimes this radial gets classified as low energy and focus gets classified as high energy. Schmidt's is certainly of the opinion that that's not how they should be classified. And there's two randomized control trials previously comparing radial to focused Shockwave therapy for the treatment of tendinopathy. One of those is patella tendon, and the other one, it escapes me for the moment, but they found no difference between groups. So that was part of our rationale around, we'll provide Shockwave. We're not going to get too caught up in the weeds about whether it's radial or focused or whatever. We do have those data about which machine was used and the intensity, and we also kept some data on pain during the session, both maximum on average. I haven't formally analysed those data. They weren't part of the main co-measures for the trial, but that was how we landed on the Shockwave dosage.
Yeah. Okay. And this maximal tolerable level, because in clinical practice, I would say that's about the standard, spaced week apart, 4 to 6 sessions, and this is how I use it. If someone's getting a really good response, we may do more if they feel as though it's really helping, but rarely do we do any more than 4. So that maximal tolerable intensity did. I know you haven't analysed the data formally, or from reports, did it change a lot? Like, was there a big variance in just how much someone could tolerate? Because I find that in the clinic quite a bit.
Yeah, I definitely find it in the clinic, but more for tendons where I think they're a bit superficial, or fascia where it's more superficial. So the plantar fascia, there's not that much covering between the shockwave head and the tissue. I find a huge variation. I treated a few in the trials, certainly not the majority. Most of them went pretty high, and proximal hamstring, these were mostly lean runners, that there's certainly a bit more covering there compared to Achilles insertion, for example. And most of them went pretty high. We went close to or maxed out the machine.
Yeah. Okay. Interesting. That's good. And moving to the exercise program, and this is where everyone loves to discuss and talk and say, well, this paper can do a great program, but let me tell you what, when I'm doing the clinic, it's way better. But the research doesn't suggest that. So we want to try and be critical of Shockwave, but also want to be critical of exercise and PRP and all the treatments that we're offering to people, and try and figure out, what is best. And I guess we can probably both agree we're going to move past the debate of, we know it needs to be individualized, and it's really about making it the person in front of you. Like, we can clearly say that. So this exercise program, it's very difficult to be able to standardize an exercise program in any RCT. So just hats off to that, because that is difficult. But how did you land on that? And could you describe what it is? And I guess, what would you say to the critique of, because it says it's individualized, what would you say to the critique of, what I would do in the clinic? Someone saying what I would do in the clinic is different to that.
Yeah. So how we landed on the program, it was a lot of long conversations. It was developed with the research team. So myself, Jill Cook, Andrew Haney, who's my primary supervisor, and John Ford. I started with what I thought was reasonable, had a very, very large piece of butcher's paper, and sat down with Jill over a couple of coffees one morning in Fairfield and tidied it up. We actually published the protocol in International Journal of Sports Physical Therapy. It was published earlier this year. It's pretty heavy reading, and to make something that was super thorough and had clear algorithmic kind of capacity, I guess, and clear detail and definitions on progressions and regressions and dosages, it was a lot of work. It was a really quite complicated paper, at least for me. It ended up being well north of 7,000 words. But that was the protocol. And sorry, next part of the question was, what was the protocol? What is it?
Yeah, sorry, and just for everybody, I'll tag all that below. Yeah, like deciding on, like the critique from other people is, well, and some critique, one or two people that I've seen is, well, I would do something different in the clinic. Now, that implies that your specificity with your program would be superior, and that would change the effect or change the outcome of this paper. And as we currently understand, and you and I were chatting offline, for whether it be the Achilles tendon, for the patellar tendon, for knee OA, that the research isn't trending in the sense of saying that specific programs seem to generally outperform a generic program. So I guess, would you say something along those lines for people that say, well, what I was doing different and that would change the outcome?
Yeah. I guess we're looking to answer a research question. And the research question was this semi-individualized rehabilitation program, was it superior or inferior or the same as a Shockwave? It's probably worth touching on that both groups received education. We might touch on the education later on. In terms of what the physiotherapy program was itself, it was a layered approach. So most people started with an isometric exercise, and there was clinician discretion here. If there was no clear benefit from isometric exercise, they were able to use their clinical discretion and abandon and move on to the next stage. But typically people would start with an isometric exercise for the hamstring, and then you would layer on more exercises onto an isotonic exercise. We used a hamstring bridge for the majority of people, and it started off with a lower intensity, high repetition, two or three sets of 10 or 15, and it progressed over 6, 8, 10 weeks to a more intense exercise, so 4 to 5 sets of 6 to 8 repetitions, slow contraction time, longer eccentric phase, long break between sets. And these were they were damn heavy exercise. It wasn't quite 6 reps, 6 rep max repetition maximum, but it wasn't too far away from it. So they were the first 2 phases. Then there was some kinetic chain work that was built in. This was typically session 3, so 2 weeks after commencing the exercise program. The big agonist for hamstring is glute max. So there was some glute max work, typically in the form of a hip thruster, with the option to progress to step-ups, option to progress if there was clear asymmetry with quadriceps strength or knee extension strength to a knee extension exercise. We had a lateral hip exercise in there if there was demonstrated to be reduced lumbopelvic motor control around the pelvis, and poor old triceps shurator calf. There was some calf exercise there as well. The smaller agonist muscle to the hamstring, but there was some calf loading as well. So a pretty typical program for the majority of people in the trial was an isometric exercise as a starting exercise, a warm-up exercise, progressing to an isotonic. And they would typically have 2 or at maximum 3 kinetic chain exercises, a hip thruster and a step-up. And that was the core of the program for the first kind of 4 to 6 weeks for most people. The compression or return to compression was the next step. And this is contentious. And there was a lot of learning for me along the way. I think there's 2 schools of thought around compression. One is you push pretty deeply into compression and build up the tolerance of the tendon to handle compressive forces. And that wasn't the approach we took. The approach we took was we test compression out, prove the athlete can handle it, and then gradually reintroduce compression in their occupational or sporting demands, whether that be running up hills, deadlifting at the gym, hockey where they're bent over a ball, that kind of stuff. And once we proved they could handle compression, we had a gradual increase in compressive loads in their occupational sporting demands and abandoned compressive exercises as part of the rehab. Not too dissimilar from the Pringles, Lauren Pringles Achilles paper from earlier this year. And that was stage 1, 2, 3, 4, so isometric stage 1, isotonic stage 2, kinetic chain stage 3, compression stage 4. And then there was an energy storage and release stage, which was stage 5. Not too many people progressed to that level for a couple of reasons. One, the majority were long distance runners and not doing a high energy demand sport. And 2, we had 12 weeks in the program. So people have been sore for an average of, I think it was 110 weeks, but over 2 years in the trial, they didn't progress. There were a few that did, but it was the minority that went under energy storage and release demands. So people will do things differently. There's a few different ways to skin a cat. I think the rehab programs, at worst, it's reasonable. I think it's pretty defensible, and people will do things differently. But as you point out, we may be splitting hairs around, is rehab program A substantially better than rehab program B? There's some commonalities there that were successful out of tendon trials, so we utilised that to individualise it a bit for hamstring.
Yeah, I guess it's always a what if, but it's not like you're giving them stretching or just avoid compression and come back into activity. I think you can safely say, as you said, it's defensible. I would extend you some faith and good faith and say it's probably a little bit more than that. Like, I think that's the majority of what probably most would do, even if some were doing that. So it's always funny where I wonder how much critique comes to the Shockwave to say, well, how much energy did you do Shockwave? And really, whereas it comes to the exercise, we're going to die on a hill. Like, I need to know exactly what RPE were they at for every single exercise, or I don't buy into it. And I was talking with my partner at bench last night, and she was a little bit skeptical. So I think if we can, that's a great explanation of the exercise program and what it meant. Would you do anything different, do you think, with that, or you're pretty happy with it? Because it sounds pretty good on my end.
The isometrics are contentious, it's fair to say. We allow clinician discretion, which I think is a good starting point. We ran a second RCT, which is probably beyond the scope of the talk today. The results are under peer review, but we ran a second RCT comparing isometric exercise to isotonic exercise for pain and strength in hamstring tendon. It was a crossover study of 20 people. Isometrics have been studied in most other tendons: Achilles tick, plantar fascia tick, elbow tick, patella tendon, of course. That was the first one with Ebony, but not in hamstring, so I kind of rounded out the PhD. So perhaps we would have slightly de-emphasised isometrics. There's still probably an argument for keeping it in. It's still loading. It's not provocative. There's clinician discretion. Not too much. Certainly not too many big things. it was one of the challenges at the start was, one, could we recruit 100 people? I felt was slightly optimistic, but who was going to come in the door? Who would we pick up? And I suspected we'd pick up a lot more ball sports athletes. In Australian rules, football, hockey, soccer. And I attempted to recruit aggressively through those populations and got nothing. I think we had one hockey player in the whole sample. It ended up being predominantly recreational / competitive distance runners. I think about 90 or maybe 92 in the trial fell into that category. So we tried to tailor the rehab program at the start to make sure it was applicable to people returning to all sports. If we knew I was going to have a cohort coming in that was 90% plus distance runners, maybe you make it slightly more distance running specific, but I'm probably splitting hairs here. I'm not actually sure how I'd do that. It's there were contingencies in the rehab program to account for all levels of activity.
Yeah. And talk me through the education part, because, seeing you got kind of two arms, and this was a case of, there was a heel pain study that came out recently comparing, Shockwave and custom foot orthoses and all these things together. And they're all about the same, but one that did just as well was custom foot orthoses plus education.
Mm-hmm.
Now, again, you can't say it's just the devices, but you wonder if you just have an education group, and I know this has been done at the moment for patellofemoral pain over in the NHS. We had Bradley O'Neill on the podcast, and that's a question of this study. If you just had a third arm that was just education, how do you think that would go? And then tell me about the education that both groups did receive.
It's very topical, you're right. And there was a systematic review that came out this year by Lindsay Townsend out of the UK, and it was basically looking at the effect of education for all tendinopathies and do other treatments provide a benefit beyond just education. And it suggests in the medium term and long term, the answer to that is no. See, sometimes I think, and it's easy with hindsight of the trials in the rearview mirror, but you think if I had 20 minutes with someone when I was down the street and they were a friend and they had proximal hamstring tendinopathy, what would I do? And I'd probably say, don't stretch or don't stretch too much. I'd say a bit of pain's okay. If it was an Achilles tendon, maybe I'd say your risk of rupture is very low because most people who rupture don't have pain. And maybe I'd say try and avoid sitting for too long on hard surface where you can practically. And then maybe I'll give them some kind of, one exercise, go down the street without any props. I suspect it's a low hanging fruit. I suspect the education is potentially a big driver of improvement. We saw that with Lindsay's systematic review. And one of the other randomised trials I had some exposure to was Charlotte Ganderton, who's a Melbourne-based physiotherapist. She ran a randomised control trial on GTPS, gluteal tendinopathy, and compared education and general exercise to education-specific exercise, and they came up the same. And I think, those two tendinopathies probably benefit a fair bit from advice. GTPS, don't lay on your side too much, don't cross your legs, don't stretch your glutes. Probably where you'd start. The education we provided, there were standardised information sheets, and the therapists were encouraged to refer back to them at every opportunity or appropriate opportunities. So there's a sheet on diagnosis, what do you have? There was an information sheet on treatment options, and that was slightly different between groups. Just, if they're in the Shockwave group, we slightly emphasised we put more detail on what Shockwave is. They're in the rehabilitation group, we put a bit more emphasis on what rehabilitation is. And the treatment options, it was surgery, no, rest, no, injections. We kind of pushed through on that, and then Shockwave and a rehabilitation program. So that was diagnosis, treatment options. We talk about the effect of compression. There's more compression at the ischial tuberosity when the hip is flexed. There's also compression at the ischial tuberosity on the tendon when you're sitting, particularly for prolonged periods or on hard surfaces. We provided some options for cushions, seat cushions. We did a monitoring pain information sheet, talking that you don't have to have 0 to 10 pain. Mild pain's okay to push through. If it's substantially worse that evening or the next day, you're probably overdoing it. A bit of pain during rehab is okay. You're not doing damage, those kind of messages. And then we had an information sheet on a tendon load hierarchy. It was kind of a graphic with an arrow at the top, an arrow at the bottom, and talk about things that put a low load through the tendon. Swimming, cycling, depending on the saddle, yoga, depending on the position, walking, uphill walking, running, uphill running, fast running, and rapid lunge in tennis, that kind of stuff. So we had a tendon load hierarchy, and the therapist was able to ad lib and individualise it based on returning to hockey or returning to gardening or returning to whatever. And we had a discharge information sheet at the end, which was a bit a bit more basic, but they were the information sheets that all the participants received. And we gave them a display folder, and they brought that into every session.
Yeah, wow, that's pretty good. I love education and I love speaking to people about their activity, but I don't think I'm even going to that extent. I try to with my talking and email, but that's great. Like the pictures and the graphs and the take homes and the understanding. That is really good education.
And those sheets, for anyone who's listening and who's keen to see them, they're freely available in the clinical commentary that we published this year in RJSPT. They're attached in as an appendix or as appendices. So they're freely available.
Put them below.
Modify them as you see fit for either the hamstring tendon or for other tendons or for any other musculoskeletal conditions you think appropriate.
So this exercise arm, of course, when you think of comparing those two, as we would say, exercise has some great side effects for bone, for tendon stiffness, for muscle mass, reducing sarcopenia, all these things. And a part of my PhD is looking at resistance training in runners. So I'm a big resistance training advocate. And when someone comes to see me for pain, I count a part of my clinical success if I can get them either meeting their physical activity guidelines a little bit more with going to the gym or doing some resistance training or doing something like that. So that's something that we say with exercise. And, comparing these two trials, we say, well, if someone's doing some exercise, even though there's no difference, there's perhaps some other benefit outside of that. What do you think? Because looking at all the outcome measures that you took, I probably wouldn't say that there is.
Yeah, we ran a qualitative study as a spin-off or as a side branch in this main RCT. So the qualitative study was new for me. I'm certainly not a qualitative researcher, but we interviewed 22 of the participants and we asked them about their experiences in the trial. And interesting, the main theme was consistent with the main RCT results, that the education provided and the rapport with the physiotherapist was a big driver of improvement. But there were these unique benefits that were reported by the physiotherapy group or the rehabilitation group, and they perceived they were stronger. They had functional strength, running up hills, running fast, that kind of stuff. And they also perceived they had increased self-efficacy, control over their destiny, or better ability to manage flare-ups, better resilience, I guess. However, as you pointed out, we measured strength in the trial, and the group started at a pretty similar level and finished at a pretty similar level. We tested them on the Nord board. So it's a Nordic curl with a forced transducer under the ankles. And it made me ask a lot of questions, because you think we threw 12 weeks of it. Was a pretty good, I thought it was a pretty reasonable strength program at these athletes, and it was heavy. They were heavy strength exercises. And then we tested them in the end, and they'd gone up by a few percent, but then showed the Shockwave group, and there's probably a learning consideration with the Nord board. You probably get slightly better with a bit more confidence when you do it a few times. So you think, what's the explanation for that? And I'm not sure if I have one that I'm happy with. You could argue that Nord board tests eccentric knee flexion torque, which picks up a bit of gastroc. I'm not sure it's a strong argument. You could argue that pain inhibits strength gains. You could argue something else. I'm actually not quite sure that came out, but it was certainly a surprise when I ran the data about there's not a substantial increase in strength in the physio group, in the rehab group. And it was contrary to the qualitative findings, where the athletes felt stronger, but then when we tested them on the Nord board, they were not stronger, at least not compared to the other intervention.
Yeah, that's a great idea, doing the qualitative to be able to see, because there may be things that exercise does do for that person, but you can't measure every single facet of their life. Someone feeling stronger running uphill, there's no validated outcome, tool for that. So that's interesting. I don't know if I've asked you yet, but just were you surprised from the results?
Yeah, I thought we'd see something. I thought we'd see some more difference between groups. Although I think, from enrolling the first participant to seeing the results put out in the computer, it was probably 4 years. And along that 4 years, we were seeing lots of trials come out where you look at the research design, you think, gee, there'll be A will clearly be better than B, or B will clearly be better than A, and they came out the same. So we're seeing more and more and more trials come out with no difference between groups. So a large part of me was surprised, but there was a trend with research over that time where no difference between groups.
Yeah. And do you think, with the majority being distance runners, that had any effect if it was someone with, maybe metabolic health or just your average person, could have changed it? Because what was their running load was just whatever their running load was, it just the typical tendon education of how it feels during the next day, stay within these parameters.
Yeah, it was
And
up to
obviously just discretion from the clinician.
up to 3 or 4 out of 10 during. If it's substantially worse, more than 2 out of 10 points worse the next day, you're overdoing it and pull back a bit. And the distance running stuff, in a way, it's more simple because you've only got so many variables. You can run faster, longer, hillier.
Yeah.
One more question there. Sorry, what was the other question you asked?
Like the clinician discretion in regards to loading, like that if they've got pain the next day, you're just going to reduce their training load, their running load.
And what I was surprised, I'll just add to that a bit more. We ran an additional study called an effect modifier analysis. It's currently under peer review as well. Although the results were presented at the recent SMA conference in Hobart. But the effect modifier analysis, also new to me, but it was looking at which baseline variables predict better response to treatment A, so Shockwave, or treatment B, rehabilitation.
Yep.
And we saw some results there, which was novel. I think it's only the second ever effect modifier analysis in tendinopathy studies, partly because they're hard to do with really small samples, and there's not a lot of really big tendon studies. So we found that males and people over 50 did better with shockwave therapy, and that females and people who are more active did better with a rehabilitation and a physiotherapy approach. And so it's a, what's the right word? It wasn't a pre-planned analysis. It was a retrospective one, but still novel data, and perhaps that goes somewhere, and we end up seeing subgroups of people that respond better to treatment A or treatment B.
Yeah, I've always, I use Shockwave in the clinic, and I'm aware of the research. There's a recent Delphi study that come out looking at the recommendation of Shockwave, and I think it was for plantar fasciopathy, Achilles tendinopathy, patella tendinopathy, and extensor tendinopathy, and 100% of them agreed that Shockwave should be included, within the treatment plan. And some studies, we actually had Peter on this podcast talking about his recent one, which he was a co-author on for insertional Achilles, where it was like Shockwave and exercise versus exercise and sham Shockwave, which wasn't a bad paper. And the critique of that is the energy wasn't high enough and so forth. But it seems to be there's some papers that do show an effect and some that don't. And you do wonder, because in the clinic, and I know this is a very, very low form of evidence, in the clinic when the people are being referred for these chronic cases, there are people that have a really good response. Now, I'm not saying whether it be the Shockwave, I'm seeing them more, could have been the same response to mental therapy, whatever it may be. There seems to be these people that do. And is it based off this? We're not great at the sub-classification of who is going to be the hyper responder. And it's great because there's no associated effects. So they don't get an outcome. And I explained that from the start. We can utilize this. We can see how we go. It doesn't take away from anything else that we're doing, which is going to take some time. And if we get a great response and you have a good response, awesome. There's no real associated or reported adverse effects other than the pain and potentially the cost. So how you now, the level you're at with your knowledge, how are you, what happens in your clinical practice now? Like, let's say a Monday morning, proximal hamstring comes in, and you're thinking, what am I going to do here? Which obviously you do know what you're going to do, but does anything change? Does your communication change? Does it just mean you just got more options now? Here's one thing, here's the other. Choose what you want to do, because some people just don't like exercise, and I get it, but that means that we've just got more option for people.
Yeah, there's a good point about patient preference, and that probably should be a consideration when we're talking about which treatment to prescribe. If they hate the idea of Shockwave, well, maybe we don't give them Shockwave. So look, I double down on the education. I think giving clear message with education, and the printed information sheets I think are fantastic, because you know what it's like when you tell someone a message. It starts off as this, ends up as Chinese whispers the next week when you see them in the clinic. But having the printed information sheets gives them something to refer back to. It's in layperson language. And I think that stuff's quite helpful. So I double down on the education. And then I've got the benefit of having Shockwave in the clinic. Start them on some early exercises. I'm doing an A+B intervention here with Shockwave plus physio. Some of them that come to me as a second opinion, or they've had these conditions for a while. They've come to me and they've done a good strength program for a couple of months. Me giving them a very, very similar strength program, I'd probably move away from that, and it's probably a good idea to try Shockwave. Often they've had great treatment. You're doing all the right things. Maybe we try making a couple of small changes. Backing off there. Sometimes they come in doing some deeper deadlifts, so often pulling them back on those. Sitting is a big disability issue with PHT, and someone's really being a bit tighter over the amount of sitting they do can change things dramatically. I had a few for the trial, and they come in and they say, "Oh, it feels like it's tight. So I've been stretching and stretching and stretching. And the stretching's often really high volume. They're stretching 20 or 30 minutes a day. And part of the session one is let's back off the stretching. And again, these are all anecdotes rather than hard data, but they come back after a week and there's 50, 60, 70% better because they've stopped the stretching. So some individualization there, you listen to them, see what they've done before. Clinical reasoning, I guess, simple but not easy.
Yeah, it's great when they come in. I say something along the lines of, well, you and I have got the benefit of hindsight. We kind of know what hasn't worked. And to be honest, the previous person you saw, I'd probably do the exact same thing or relatively the same. So it just gives us the benefit that we know we need to change. You mentioned the kind of A plus B because, you could read this paper and then conclude, well, if they're both really good, if I add them together, that means they're really, really good. But obviously research doesn't work like that. Do you think based off this, it's still, logical if someone, again, comes in on Monday morning that you would gravitate towards the Shockwave on the first appointment based off this paper if they hadn't done anything at all? Let's say they've been going on for a couple of months, or maybe just your standard program. Standard time with pain. Would you gravitate more towards that earlier now?
Yeah, it depends a bit. It depends on what they've been doing before. It depends have they been stretching. You look for their training history. And that was part of the workup for this trial. What precipitated the onset of their symptoms? Did they go from running no hills to a lot of hills, or no faster into faster running? So it depends a bit. But it would be more than 50% chance I do Shockwave in the first session, just thinking back on the ones I've seen in the last 12 months.
Yeah. And is there any plan to, do you think, I imagine if you're comparing a focus versus radial, do you think there would be any difference there? Because that's another, not critique, that's just another thought around the energy and,
good point.
Whether that be the...
We've got those data, and eventually I'll get around to analysing it. The tricky thing is there were relatively few focus machines when we started this. I think there's only one in the trial, and I think that trial treated that clinic treated about 22, 23 participants in the trial, so about, a quarter. So we can probably pull out the data with that clinic compared to the other clinics, but then you can't control for the other variables. That clinic, they saw one of two clinicians, either me or Victoria. So if the people who had focus Shockwave get better, is it because they saw me or Victoria, or is it because they had focus Shockwave? There's too many variables, so I can't do a really high rigor. So it's probably worth for interest pulling it out at some stage. I've got the data on the clinical notes. My gut feel is we wouldn't see a difference.
Yeah. And, you obviously learning a bit about Shockwave as well for this. Do you think we're going to be able to design better trials and maybe see some meaningful difference? And it's the same thing of we just haven't got the greatest understanding yet how to classify, who's going to best respond, not just to Shockwave, but radial versus focused.
Yeah, one of the tricky things about these tendon trials is there's not that many with really big sample size. We had 100. I think it's the fourth biggest lower limb.
It's a lot of people.
Yeah, lower limb tendinopathy trial with a rehab component. There's a reason why that had I think it was 100 or 106. It was heel insert versus sham heel insert out of Melbourne as well. But they're a bit easier to do because the intervention's shorter. We had 6 full sessions of treatment. I think I screened a bit over 200 people to get the 100 into the trial. If you want to have the study adequately powered, and ours you could argue wasn't. We initially pitched it as a pilot because it was tricky to calculate the sample size with the outcome measures. That if I had unlimited resources, we'd do a 3-arm or a 4-arm trial, like the Hemrick Rial one on plantar fascia, and measure all these variables. But even at 100, we're underpowered. So to answer these questions well, you need bigger volumes of people, and it's a lot of work. I'd love to keep doing some research, but I don't think I'll be the primary researcher in that one unless something changes.
Yeah, unless a couple of $1 million drops out of the sky tomorrow. Yeah. So what do you think now for other conditions? Do you think we'll start to see, because you've said for the insertional Achilles, do you think we'll see things like these types of trials in other conditions show similar outcomes? Do you think there's something uniquely different about the proximal hamstring to the Achilles, to the patella, to the plantar fascia? Do you think it's just why would you get this outcome and maybe not in others, in other tendons?
Yeah, I think about that a lot. I think patella tendon, more a jumper's condition generally, more high energy storage and release. So there's some differences there, and it's probably more in younger jumping athletes. You're probably seeing more people under 30 with patellar tendon. So it's a different cohort. Achilles tendon pain occurs across the lifespan, the more diverse cohort. As are actually pretty homogenous, mid-40s, 3/4 were female, mostly distance runners. I don't know is the short answer what we'd see with those trials. It's being done on Shockwave, and the study, Peter was a co-author. I think the lead author was out of, I forget his surname, which is terrible, out of Saudi Arabia on sham and
Yes, I
Shockwave
can't
issue.
remember.
So
Yeah.
there's certainly stuff happening. I'm not sure if we design the same trial for Achilles or patella, what we'd see. And so patella tendon seems tricky to treat with Shockwave. I don't think the results are as good compared to insertion like Achilles or plantar fascia.
Yeah. And can I ask, with the Shockwave, how, like, the application, to the proximal tendon,
Yeah.
were you, kind of holding and moving around? Were you, how were you basically doing it for those 2,000 shocks?
Yeah. So patient or participant was in supine. That was a preferred position, not at 90. Most people ended up doing it in supine. Hip was at 90 degrees of flexion. This was modeled on the Caccio administration of Shockwave. We palpated their ischial tuberosity with the thumb and then rolled down to the proximal hamstring tendon complex. If there was a tender area or the most tender area, we marked that with a pen. They weren't always tender, and using palpation to diagnose was a bit contentious. I think it's a bit different with PHT compared to Achilles. It's a bit deeper. Well, we marked the most tender area where it was practical with a pen, applied the gel, turned the shockwave on, and then it radiated around the area. It was a pretty small area of administration. The sciatic nerve's pretty close. It's only about half an inch or 1.2 centimetres lateral.
Yeah.
I haven't seen any side effects, touch wood, from someone having shockwave over their sciatic nerve, but we tried to avoid that. So, mostly lean athletes, it's pretty easy to find with palpation the relevant area.
Yeah, and thank you for your time so far. I've only got one more question. I thought it'd only be 30 minutes, but it's always away. When you had administered Shockwave, and Peter spoke about this, included within the trial that he did, and they haven't published the data, but he was saying they have the data to be analysed, that there wasn't any difference with the post-Shockwave discomfort, like that analgesic effect, and clinically, I would see that, especially with the heel. It's amazing. People can get up and put pressure through their heel, and where you just hit something for hard enough, for long enough, it feels better. And you do wonder just like the power of that for someone, and how that increases their self-efficacy and their feeling about what's going on. Wow, you could change my pain. That's important to me. Did and there's contentious whether isometrics can do that. Obviously, it's patient specific. But do you have a plan to analyze that, or did you see that, and do you think that meant anything for people?
Yeah, we didn't capture those data, unfortunately. You think how would you capture them? You'd look at sitting symptoms in the 24 hours post-treatment. It'd probably be the best way to do it. We actually looked at that for the other RCT that's under review, the isometric one. We looked at sitting symptoms in the 24 hours following, in that case, an exercise bolus. Looking at,
that was isometric versus isotonic.
Yeah, that's right. So we measured pain with an arabesque at 0 minutes, 45 minutes, and 24 hours. We measured sitting symptoms on a patient-specific functional scale in the 24 hours prior to treatment and 24 hours after treatment. And we measured strength at 0 minutes and 45 minutes. But for the main RCT, the one we're discussing today, we didn't measure the acute response from Shockwave. And I guess partly because we would have had to compare it to the acute response to the exercise that was done in the gym on the day of treatment. Yeah. I've got the same anecdotes as you from clinical practice. And when I was new to Shockwave, people would stand up after I treated their plantar fascia, like, it feels. And I tried to turn my preconceived notion. I'm like, are they really that much better? Like, it was quite surprising. It really blew me away how much. And there's got to be something acute there, whether it's pain gate theory or the diffuse noxious inhibitory control or something that makes these immediate pain change. I'm convinced it's more than placebo. It was quite dramatic, particularly for plantar fascia. That's probably where I had the better results. With hamstring, it's a bit harder to tell because they're just kind of hanging around. It's not that sore or walking around slowly. You have to go get them sitting in their office chair for their calf and half an hour to test it out.
Yeah, it's interesting how it does that. You got to think that that's meaningful for someone. I mean, I've had a sore knee. And again, this is N equals 1. And I remember a physio mate of mine just internally rotated my leg and we got like 15 degrees extra of knee flexion. I haven't had many injuries over my life. And I was like, your hands are magic. This is amazing. Why don't I have any pain anymore? And I was like, this is more than anything, any injection or shockwave you could do for me. So it is meaningful. For people reading this, and the last question, when people are reading this, and we'll have it tagged in the show notes, is there anything that you want people to take away? I mean, it sounds like you've already done a whole lot in your career so far, but it sounds like you've got an awesome paper under review, and we'll have all that tagged. And when it comes out, I'll share it on my socials and add this to the show notes. But, there's the thousands of clinicians listening. Is there anything that you would want them to consider when reading this paper, or to take away, or things that, they should be aware of? And it doesn't have to be related to shockwave or exercise, literally just with proximal or just general in kind of physiotherapy philosophy. What do you think?
I think you'll read beyond the headline. It's easy to say because often when people are time crunched, you go and read the abstract or the conclusion and mark.
It's a great Instagram, it's a good Instagram paper. You can just say, shockwave's not as good as physio.
I remember hearing Ross Tucker on a podcast. He's a South African sports scientist a while ago.
Yeah.
He was talking about when he interviews guests or when he meets with people, and if they ask the guest a question, the answer is yes 100% or no 100%. He doesn't trust their answer. He said there's very few things that have got no nuance. And I think he had Louise Burke, the sports dietitian from basically AIS for a long time on the show. And he'd asked her a question that a 5 or 6 minute answer because there's nuance and it depends and and it suggests this and suggests that. The black and white's good for social media and a quick caption, but I haven't got that. But I guess to answer the question, I think go and read the clinical commentary piece that we published earlier this year. It's got some good clinical reasoning takeaways about prescribing exercise. Now, look, it didn't stack up better than shockwave in this situation, but it gives you some good review of clinical reason there, whereas you could argue shockwave doesn't have much clinical reason. Put it on the sore spot and press the button and off you go. I'm simplifying a bit. And then the education sheets that are an appendix to that paper, I think are quite helpful. And we borrowed the language from some of the back pain trials that I was involved in previously. So I need to acknowledge that with John Ford's work. The language is similar but updated for tendon and made more relevant for tendon. I think that, if you're looking to help patients, that's probably a good start with session 1. Again, you choose your patient wisely. Someone before you delivers education day 1, maybe there's a bit more you can do. But the content and the information sheet I think is quite helpful. I'd love to, if I had unlimited resources, compare the education only to the other interventions. While I think that the other thing is we matched the intervention sessions here. There were 6 sessions for each group. I think that's important. You've got treatment arm A getting 3 sessions and treatment arm B getting 9 sessions. You could argue that just the exposure to the therapist was what drove any differences there. So that's a bit off topic, but I'd encourage them to read the clinical commentary paper and the attached education sheets.
Yeah. And what's next for yourself? What's coming up?
I'm submitting my PhD tonight. Yeah, rest. It was a lot of work. Like I was working a lot during this time, like 0.9 plus. And changed jobs that had 2 kids along the way. So busy 7 years. And that's probably why it took 7.5 years rather than the 3 like the full-time PhD. And I'm kind of glad I was part-time, but we had COVID along the way and really put a halt to things for 18 months. I wouldn't have been able to do it in the full-time PhD time. But anyway, so submitting tonight, so good timing to be on the podcast today.
I can't believe that coincidence. That's huge. Congratulations.
Press the button in half an hour or so. I'm really keen to be involved in research, and I'll give a quick plug to the group I work with here. I love the RCT model within a network. You get the PhD student that gets a large-scale RCT. You get the reputation for the group that provides it, so life care in this situation. And you can get 10, 12, 15 young, enthusiastic clinicians to become much better at treating a condition which can become I learned how to treat multidirectional instability of the shoulder well under Sarah Warby and Lynn Watson's work, and back pain under the STOPS trial with John Ford and Andrew Haney. So it was good for me clinically when I was a junior clinician. So if anyone's looking to do research, whether it's tendon or otherwise, and they would like to have a go at putting an RCT together, please feel free to get in touch. I'm happy to chat. I'm no expert academic by any means, but I'm happy to put you in touch with the right people. And if there's a scope for me to be involved, I'd love to be involved. I think that's a good model for keen researchers.
Yeah, no, I'll tag all that below. Mate, thank you so much for coming on. I mean, I've only just started my PhD journey, and I can't imagine what it feels like to hit submit. I mean, when you put out so much good quality and just, stuff that's really relevant, and we talk about clinical relevant papers, like something like this is awesome. And it's just great to get people thinking and discussing and talk about education and exercise, and we'll have all the education pieces tagged in the notes. So thank you for that, and hopefully people can have them in the clinic. But enjoy hitting that submit button. That's going to be an amazing feeling.
Thanks, Blake. Thanks again for having me on the podcast. It's appreciated.